I'm Dr. Asif. Welcome you all to our new session that is a PACES respiratory scar. We're going to have a thorough lookout about the common scar that we encounter in the PACES respi station. Okay, so without making any further delay, I'm going to proceed. The first important scar is the VAS scar. Okay, we call it video assisted thoracoscopic surgery scar. Okay, there could be a scar, it's a keyhole scar approximately 1 to 2 centimeter in size, situated in the lateral chest wall. And another important thing that we should remember, just below the scar mark, there could be a camera port scar. Okay, so it's a keyhole surgery scar which is made usually into the thorax. It's approximately 2 centimeter in size, because there is another scar mark more than 2 centimeter in size that could be open lung biopsy scar. Whenever you encounter this VAT scar in the PACES examination, always remember it should be done in case of biopsy or removal of suspicious small masses. Second thing, it could be an important guideline landmark, particularly if you want to do the pleurodosis in recurrent pleural effusion and suspected pneumothorax case when the pleurodosis is indicated. And third important indication is the mediastinal lymph node biopsy. Okay, so we should always remember this is scar mark. We're going to see another picture. As you can see, it's a small scar mark, approximately 2 centimeter in size, particularly situated in the lateral chest wall. Okay, as you can see, these are a small VAT scar situated in the lateral chest wall. It is approximately 1 to 2 centimeter in size. Next important thing, the open lung biopsy scar, it should be greater than 3 centimeter or particularly 3 to 4 centimeter in length, and it must be greater than the video assisted thoracoscopic scar. Okay, so open lung biopsy is another scar we should never forget. Okay, it is also situated in particularly in the lateral chest wall. Okay, previously, sometimes in suspected mediastinal cases, or in order to perform some biopsy in particularly mediastinal case like lymphoma or tuberculosis or sarcoidosis, sometimes there could be mediastinoscopic scar. It is situated just above the sternum. As we can clearly see, it is above the sternum. Okay, so it is just 1 centimeter above the sternal notch, and particularly we do it in case of suspected mediastinal lymphadenopathy, and we should always think of this in particular case of sarcoidosis, tuberculosis, or lymphoma, or even some cases of bronchial malignancy as well. Another thing that we used to do in the past, so this is called phrenic nerve crush scar. In particular case of tuberculosis, in a suspected TB lung, that lung will be, make less compatible to for activity by doing these sorts of phrenic nerve crush scar, or another procedure that we used to perform in the past, that is the thoracolplasty. Okay, so this is a very small scar mark situated just in the apex of the lung, in particularly when the phrenic nerve is situated, where the phrenic nerve is situated particularly. So phrenic nerve scar mark we all should remember in particular cases, though it is so rare, but we should keep it in mind. Okay. Another thing, the most important, the clamshell incision, we do it in particular case of double lung transplant. Okay, we should always remember it's sometimes similar to like the Mercedes-Benz scar, but the issue is that scar in the abdomen. Okay, and that scar will be typical of Mercedes-Benz. Okay, there could be another just in the angle, there will be another perpendicular line, just like a Mercedes-Benz. And this is the clamshell incision. It is situated in the thoracic wall, and it is indicated for the dual lung transplant. Okay, so that is the important thing. It is a bilateral anterolateral thoracotomy or transverse sternotomy scar. It is a curvilinear W shape that extends across the anterior chest wall from the mid-maxillary line on the either side, located in the submammary fold. So it is important thing. We should remember the indication, the double lung transplant. Okay, whenever you are suspecting a double lung transplant with clamshell scar, always check for tracheostomy scar. Okay, there could be associated tracheostomy. And another important thing, whenever you are getting a lung transplant, always search for immunosuppression, particularly the steroid or the cyclosporine. Okay. Another thing is that sometimes lung transplant or pneumonectomy can be performed with midline sternotomy scar mark. Okay. So whenever you are getting a midline sternotomy scar mark, apart from the cardiac issues like the mitral valve replacement, aortic valve replacement, dual valve replacement, CABG, or something called the, the ASD-VSD closure or repair, we should also remember the lung transplant as well. Okay, so new scar mark is nowadays found in particularly bilateral lung transplant. That is the video-assisted minimally invasive approach. In that case, it is not like the clamshell. It will not, touch in the midline like the clamshell scar mark. It will be situated just in the lateral. As you can see, in case of both lateral, is this lateral and this lateral, there is a typical small scar mark situated in the lateral part of the chest. That is the video-assisted minimally invasive approach in particularly bilateral lung transplant. Okay, we should remember this. So let's proceed. So some issues that we should remember: evidence of immunosuppressive therapy, particularly the steroid toxicity. We can get the bruising, particularly the fungal infection, the Cushingoid appearance, and never forget the proximal myopathy that we should check in particular case of steroid uses. Second thing is that the cyclosporin. We can check the tremor in the outstretched hand, and apart from that, there could be gingival hyperplasia or gum hypertrophy. Sometimes there could be excessive non-androgen dependent hair growth like the hypertrichosis associated with the cyclosporin. Okay, so whenever getting a lung transplant, though it is quite rare in PACES, we should check for the evidence of immunosuppressive therapy. The issue is that when you do the double lung transplant, in particular case of cystic fibrosis, bilateral extensive bronchiectasis, sometimes in case of COPD, alpha-1 antitrypsin deficiency, sarcoidosis, or even pulmonary arterial hypertension. Okay, so we should remember. Another thing is quite common, that is in case of myasthenia gravis, JLS myasthenia gravis, sometimes there could be thymectomy. So there is the anodal midline sternotomy scar mark. It is situated a bit above. So it is thymectomy scar. Okay. In particular, whenever you're suspecting a case of myasthenia gravis, always look for this scar mark. Okay. So this is some sorts of, demarcation. We will proceed. Okay. So the issue is that the most important is scar mark. That is the lateral thoracotomy scar. We should never ever forget. It will be situated in the anterior chest as well as back of the chest. And sometimes the chest scar mark is practically more in the back side. So if we see from front of the chest, we can easily miss the scar mark. We should always check the back for the lateral thoracotomy scar mark. Okay, so the scar mark, as we can also see, the scar mark can be very faint sometimes, and as we can see the third picture. Okay, so the scar may be posterior, which can easily miss, and sometimes the scar mark can be very faint. So that protocol, that most important part of today's session, the protocol. Whenever we are getting a lateral thoracotomy scar, first of all, we should always check the position of the trachea. Okay, so we should check that whether the trachea shifted towards the side of the scar or whether the trachea is in the normal place. Okay, if we are getting a lateral thoracotomy scar mark and the trachea shifted towards the side of the scar mark, we should check. The next approach will be, what about the lower zone breath sound? If the lower zone breath sound is diminished, in particular case of shifting trachea, we will be considering pneumonectomy. If the lower zone breath sound is present in a shifting trachea, so we will consider that it is a case of upper lobectomy. I'm repeating again, if we get a lateral thoracotomy scar, we need to check two things. First thing is that what is the position of the trachea, and second thing is that what about the lower zone breath sound? If the trachea shifted towards the site of the scar mark, there could be the possibility of upper lobectomy or pneumonectomy. Though very, very rare cases, sometimes lower lobectomy can have trachea shifting, but that is not one of the facts we should remember regarding giving the examination in PACES. Okay, so the issue is that if you get the lateral thoracotomy scar mark, we should check the position of the trachea. Okay, if the trachea is shifted towards the scar mark, we need to check whether it is pneumonectomy or upper lobectomy. In case of pneumonectomy, the lower zone breath sound will be diminished to absent, and in case of upper lobectomy, lower zone breath sound will be present. Okay, so the issue is that if the trachea shifted towards the site of the scar mark, we need to check the lower zone breath sound. If lower zone breath sound is present, it's a case of upper lobectomy. If lower zone breath sound is absent, it's a case of possible pneumonectomy. Second thing is that if the position of the trachea is normal, it is situated central, we should check for lower zone breath sound. If the lower zone breath sound is diminished in a case of normal position trachea, we should confidently say this, it is a case of lower lobectomy. Okay, if we get a position of the trachea is normal, apart from that, lower zone breath sound is also normal. Still, our first possibility will be lower lobectomy. Why the lower lobectomy? Because there could be compensatory hyperplasia of the lung causing lower lobe. The lower lobe is absent practically because of lobectomy, but the issue is that the lung is hyperplasia, the compensatory hyperplasia causing that diminished breath sound to be gone. Okay, so if we get the position of the trachea to be normal, the lower zone breath sound is absent, then we can confidently say it's a lower lobectomy. If the position of the trachea is normal, it's central, and lower zone breath sound is present, still the possibility will be lower lobectomy. And other possibility will be decortication, or it could be lung transplant. But in case of lung transplant, we'll be getting the features of immunosuppression more commonly. Okay, so the issue is that if you get a lateral thoracotomy scar mark, it is a lower lobectomy that we should always keep in mind. Okay, particularly whenever we're getting the position of the trachea is central. Whenever the position of the trachea is central, in particular in a scar mark, whenever the lower zone breath sound is present or not, we should always remember the lower lobectomy. Okay, so the common causes is, and apart from that, after establishing the facts, we should check for possible cause of lobectomy, okay, or pneumonectomy. There could be some chance, common chance, like the bronchial malignancy or the bronchiectasis. These are the common cause. So we should look for clubbing. In a case of pneumonectomy or lobectomy, if the patient has clubbing, it could be due to bronchiectasis or bronchial malignancy. Second thing is the telangiectasia. We should not forget. Sometimes localized arteriovenous malformation can also lead to a lobectomy. Okay, so telangiectasia, and particularly perioral telangiectasia, can lead such to a cause like hereditary hemorrhagic telangiectasia. Apart from lymphadenopathy, could be a case of bronchial malignancy underlying lobectomy or pneumonectomy. And particularly in the normal lung or other lung, there is coarse crackles present. So there could be more chance of bronchiectasis as the cause of lobectomy or pneumonectomy. Okay, and though it's very, very, very rare, we should keep in mind in a small fact, like sometimes in a very small cases, trachea may be deviated, particularly in lower lobectomy. But that is not one of the information I want to give you in this session. Okay, so we should remember this chart according to protocol. Okay, and last thing is that the common indication of pneumonectomy. We should remember the bronchial malignancy is a very common cause. And second thing is that extensive bronchiectasis or post-TB bronchiectasis causing destroyed lung. Whenever we're getting bronchial malignancy or we're getting bronchiectasis or tuberculosis causing destroyed lung, these are the indication of pneumonectomy. And if we consider the lobectomy, we should say like this. The common cause of underlying lobectomy should be considered whatever the findings. If we are getting some clubbing, we are getting coarse crackles, we should say the bronchiectasis could be a cause of lobectomy. Okay, if we get nothing, we should say like this. Localized bronchiectasis causing massive hemoptysis, refractory to medical management. Second thing is that it could be localized malignancy, it could be localized lung abscess, there could be sometimes fungal ball or aspergilloma like that, and solitary pulmonary nodule of suspicious etiology, that could be another cause, and last but not the least, the pulmonary arteriovenous malformation. Okay, these are the causes of lobectomy. And particularly if we want to consider the aspergilloma, it is more prevalent in case of upper lobectomy. I have prepared the site from the following resources. So thank you so much for your kind consideration. If you like the video, please subscribe the channel. Thank you so much, so that I can make more videos for you guys. Thank you so much.